Welcome back to The Wellness Effect. Have you subscribed yet? If you haven't, you might miss out on this and many other insightful discussions. Today, urologist Dr. Raymond Campbell joins me in studio to help us understand the testing and diagnosis of prostate cancer a bit more. Welcome, Dr. Campbell.
Hi, Seth.
I'm really looking forward to discussing this topic because I think it affects a lot of men.
Prostate cancer is certainly the breast cancer for men. It's the most common solid tumor found in men, and it's I think that it hasn't received the airtime that most of the other diseases have.
What are some of the tests and procedures that urologists use to diagnose prostate cancer?
The problem with prostate cancer is that it's very sneaky. It's difficult. It doesn't have very many obvious symptoms. Sometimes people will complain of difficulty in voiding. Sometimes they'll complain of pain in and around their pelvic area or in their bones. They might have loss of weight. But unfortunately, all of these are late symptoms. The best way to actually diagnose it is early in its disease and regular checkups from the age of 40 if you have a family history of prostate cancer, or 45 if you don't, is recommended.
And how do urologists determine whether to treat prostate cancer or surveillance around it as well?
If I can just go back to the how you detect it.
Sure, go for it.
I think a lot of men are worried about the digital rectal examination, which has been the cornerstone, the bedrock of how we test for prostate cancer, which is where we would do a finger in the anal canal and feel the prostate. The prostate sits roughly at the mouth of the bladder and it's felt through the rectum, but you can only feel about a quarter of its surface. So it's at best, a estimate of what is happening in the prostate. We still make use of it, and I don't think that it has a prominent place as it used to. I think that blood counts, regular blood counts, and there are very good validated tools to check your risk for prostate cancer. And these tools would make use of things like the size of the prostate versus the how rapidly the prostate count increases, and we do density checks and so forth, and it gives a probability score of how likely it is that you do or do not have prostate cancer. Based on those scoring or those risk calculators, we then decide to investigate or to reassure the patients. There are other tests, and I think that here it's important to mention too. Ultrasound we use often when we're doing the biopsies of the prostate, because it's the only definitive test for a prostate cancer is to do a biopsy of the prostate and send that for histological or tissue review. I think that MRI is slowly taking a place as guideline level modality for screening for prostate cancer. So what happens is that the MR can see the prostate and give a grading between 1 and 5, and anything 3, 4, or 5 needs to be investigated. What's nice about that is, firstly, the 1s and 2s that are diagnosed. So sometimes you've got a high prostate count, but you've only got a lesion 1 or 2. You can confidently tell that person, relax, especially if you're using the calculator additionally. But if someone has a 3, 4, 5 lesion, it not only shows that there is a high-risk lesion, but it shows where you need to go and target your biopsies when you are doing the ultrasound-guided biopsies. So that helps a lot. Bone scans are normally used when we think that there is spread outside of the prostate.
I see.
And you'd preferably not want that. And then there is also on the horizon, and it's moving from research to mainstream, PET CT scans. So that's a radionuclide test where you inject a tracer, and it also goes and sits in areas where there are prostate cancer, within the prostate as well as outside.
So, doctor, how then do you determine treatment?
Yeah, so here it is a combination of factors. The grading of the cancer, so how aggressive or not it is, that's a number one. And we use a score out of 10 when we're grading the prostate cancer. The lower the score, the more benign or indolent the cancer is. the higher the score is, the more aggressive the tumors are. So that's the first consideration. The second one is the person sitting in front of you. What sort of health status are they in? We have a very rough estimate. If I think that this person will live at least another 10 years, there is merit or value in treating the person. But that is like I say, it's a very coarse method of testing. So if someone is likely to die from something else imminently, probably we would just do symptomatic management for that patient. So the quality of the client sitting in front of you. The risk appetite. What are they up for? So there are different modalities, and some of them have more PT involved in them. In other words, regular checkups. If we're doing something like active surveillance, you have to come in for regular checkups and regular biopsies.
Okay.
And if that isn't a problem for you and you have the right type of cancer that fits in with that, of course we can. And then, of course, if you're in a curative stage where if removal will cure you, there's the option of removing it via open surgery, laparoscopic surgery, and lately, I mean, the craze is robotic surgery. So the unit where I work at was the first in the country to have a robotic machine, a Da Vinci machine, and we've done well over 3,000 of these cases at our unit.
Wow.
So I think it's definitely the country leader for that. So you can do that. You can place radioactive seeds in the prostate. And then, of course, there are other modalities where you're just treating symptomatically. If I think that this cancer has spread beyond, but you're still struggling to pass urine or to hold your urine, you can then do something to open up the channel and so that the person can void easier. So it's horses for courses. No two patients are the same. It's literally a case of what are your symptoms? How is your general condition? What type of cancer do you have? And what is your risk appetite? I think it's a hybrid of these things, and it's a discussion to be had firstly with the patient and then with the family as well, because they need to support or manage this patient together. Yeah.
I've heard a lot about active surveillance. What type of cancer constitutes active surveillance? I've heard individuals living for 20 years under this. But what is it?
Yeah, so active surveillance by definition means I'm watching this cancer with the intent to cure if needs be.
Okay.
So the opposite of that very coin is something called watchful waiting, which is I watch until you have symptoms, but it does spread beyond the prostate, and I'll manage the symptoms as and when they present. Active surveillance means I watch this cancer. I think it is a indolent cancer, a sleeping cancer, and we keep on making sure that it's still sleeping. And if it were to become more aggressive or start showing signs of either upstaging or the PSA count rising, I still have the the window of opportunity for curative care remains. That's the basis of active surveillance.
All right. And what sort of percentage of men do you find having this level of cancer?
So this is an excellent question. I think that the overtreatment for prostate cancer is something that we, as the urology fraternity, we get accused of quite a bit, meaning that a lot more patients can be managed in the basket of active surveillance, but aren't. But that isn't necessarily just from the urologist side. Some patients are of such nature, they're so nervous and take it out. And you need to respect that portion as well. So it's a two-way, it's a shared responsibility discussion, if I can put it that way. But we should be doing more active surveillance. And if a patient does fit the profile, you should encourage them to, but you cannot enforce it.
Okay. And sorry, to that point, what is the profile of an individual who can have the active surveillance treatment?
Yeah, so there's very strict guidelines around that. The prostate count should be under a certain level. The scoring that I spoke of, it's called the Gleason, is the guy who described it. So the Gleason score must be a very strict score. It cannot be more than 7, but it must be not just 7. So it's 2 scores. They take the most common one that they see and the next most common type. So it's 2 scores out of 5. So it can be a 3 plus 4, but it cannot be a 4 plus 3. So it must be a 3 plus 4 or less. It must be a PSA count. We use a score of less than 10, and there must not be a velocity, in other words, an increase over time, over a certain velocity. If you remain within these confines, you're still a candidate for active surveillance.
Okay.
Because I know that even if there were to be changes, I can still cure you.
And what is the importance of a multidisciplinary approach in treating patients who have prostate cancer?
Yeah, sometimes surgeons do have this sort of God complex where we think we can do everything, but we don't really. We need inputs from the psychologists, we need inputs from the family, we need inputs from the oncologists, the dietitians, all of our, and studies have shown over and over that a multidisciplinary, in other words, if I get the opinions of others, these patients, firstly, they accept their fate or their diagnosis better. And secondly, or most importantly, the outcomes are better. So I think that in a high volume area, it's difficult in a far-flung area to assemble a multidisciplinary team. But I must say, with the advent of things like telemedicine and teams and so forth, it's not impossible. I think it's something to consider to get the opinions of others. So a multidisciplinary team is a must for high volume centers, and it is an option. If you're going to take the burden of treating the cancers, I think it's incumbent on you to take the responsibility of getting other opinions.
And what sort of resources or support do you recommend to patients and families navigating a prostate cancer diagnosis?
Yeah, so there are, country to country, there are things like foundations that support. And in South Africa, we have a very active prostate cancer foundation. So you can almost never give your patient enough information. They can decide how to consume it, how to assimilate it, and which questions to ask. But we're very keen on giving our patients access to information in a language that they can understand. So counseling is super important. If you want to reach a point of informed consent and them understanding the process that they're embarking on or the journey that they're going to, I think that you need to put them in touch with enough information to be able to make good decisions about themselves, because ultimately these are important decisions. Again, I come back to, I think it's a shared responsibility. I don't think the days where I decide what happens and you just follow is applicable anymore. Prostate Cancer Foundation does have more info for patients as well as for family. And I think that there are support groups in most big metros and cities, and I think it's important to put them in touch. At high volume centers like where I work, I think that there are also aids that they can use or utilize, make use of in order to make their journeys easier.
And what are some of the common side effects?
So I normally tell them in the order of importance. My first job is to get you cancer-free. My second job is to get you continent. In other words, that you can have control over your urine. And my third job is to get you potent, to preserve potency. In other words, get you still having erections afterwards. These are the three cardinal pillars. The other things like psychological support, because they become, quite emotional. Some of the treatments that we give for metastatic disease attacks their bone density, it makes them emotionally labile. In other words, they can mood swings and so forth. They can get hot flushes. But those are more for the cancers where it is spread. But if we're talking curative, the most important things is cancer-free, continence, and potency. So we pay a lot of attention to our own stats, how we do the procedures. So a younger person who doesn't have pre-existing diseases like diabetes, hypertension, and so forth, and who is potent, will have a better outcome than an older patient who is already having pre-existing erectile dysfunction and who has difficult anatomy, for argument's sake. So for these reasons, there are things that matter, and then I can tell them, look, in this unit, what we're seeing is our outcomes look like this. And the patient gets a chance to make a good decision based on facts.
Thank you, Dr. Campbell, for such an engaging conversation and really helping us as men understand prostate cancer.
Thank you very much for having me.
And thank you to our viewers again for watching. To watch previous and upcoming episodes of The Wellness Effect, subscribe and hit the notification bell. See you next time. BankMed, the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health.